Okay, I think the participant numbers are slowing down a little bit. I think others will continue to join us, but I think for the sake of time, we can go ahead and get started. Thank you so much for joining us for our Systems for Action Research and Progress webinar series. This is a series that we have every 2 weeks where we invite the Systems for Action research teams to come and provide some real-time updates on the research projects that they're doing. Today, you are joining to hear from the Stanford University team, whose project is titled Integrating Health and Social Services Through a Novel Independent Practice Association. I believe this is their second or third time presenting in our Research and Progress webinar series. It's been about a year since they've presented, so I think they're going to have some really exciting updates for us here. This team is a team that applied for a funding opportunity because we release annual funding opportunities at Systems for Action. All projects that are funded through our funding opportunities all have one thing in common, that they have an innovative system alignment mechanism, which means that they're trying to align across sectors, specifically the public health, social, and medical service sectors. So with that, can we go to the next slide? Or Elena, can we go ahead and share slides? I was looking at your PowerPoint on my other monitor. Here we go. Perfect. Okay, next slide. A couple of housekeeping things to discuss before we jump into the presentation. We're here in the welcome, which will be very brief. Our presenters today are Dr. Shaw, Dr. Wagner, and Dr. Rosenbaum, and they're joined by Amanda Duff, who is going to be providing some really great commentary. And then they'll be speaking for about 45 minutes, and we'll provide some time at the end, about 10 to 15 minutes for questions and answers. So if you have any questions at any point during today's session, would you please locate the Q&A box at the bottom of your Zoom screen, enter in your question, and we'll make sure to address that at the end of today's session. One other item to note is that today's session is being recorded, so we will email out the recording as well as a PDF of the slides from today's presentation after the session. Next slide, please. Okay, I am going to be quiet and hand it over to the team. Elena, I'm going to hand it over to you so you can start with the introductions and the rest of your team can jump in.
All right, everyone. Thank you for joining us today. I'm excited to get this conversation started. So I'm the medical director of Healthy Alliance and also a family physician. We're an organization in upstate New York that has an integrated network of healthcare, behavioral health, social care providers, and we're doing a lot of work in New York State. Happy to work with Stanford on the study. And I'm going to hand over to our next person, Jonathan, for his own introduction.
Thanks so much, Elena. Good morning. I'm Jonathan Shaw. I'm also a family physician. I'm a health services researcher here at Stanford University. One of the medical leads of our evaluation sciences unit, which does implementation science. And I will hand it over to my colleague, Todd Wagner.
Great to meet you all. Todd Wagner. I'm a professor here, a health economist. I also run a research center at the Palo Alto VA, and I've always been attracted to working in sort of understanding the financing for what we think of as safety net hospitals. So it's a great pleasure to be with Elena and Jonathan and the team here. Thanks.
Hi, I'm Amanda Duff. I'm currently the Strategic Planning Director for Healthy Capital District, and have worked closely with Healthy Alliance for a number of years. I'm really excited to kind of contribute some of my experience from both the community-based organization and FQHC perspective. So thank you all for being here.
Thank you. So I'm going to start a conversation. And first, we're going to go through a little bit of the history and context of Healthy Alliance. We'll spend some time with our study aims and early lessons learned and look forward into future. So we have more and more evidence that social care services improve health. I think a lot of folks on the call are seeing that, developing. And yet, we find that sustainable funding for social care remains elusive, and that's partly because of the wrong pocket problem. And this occurs when an organization won't fund a social care program because the return goes to another organization. So this is why we were funded. We were funded to study Healthy Alliance IPA as an innovative solution to the wrong pocket phenomena. And since we were funded, we have seen some very dynamic changes at CMS and state policy. And so we wanted to share also how that has impacted our work and how we're viewing the impact of our study. So I'll start by talking about Healthy Alliance. As I mentioned before, we're an integrated network of behavioral health, and social care providers. We were funded by DISRIP initially, and a bunch of community providers decided that the best way to improve the health of the community would be to develop some sort of relationship that was more established between health and social care providers. So with the use of a referral platform and a team of individuals, we have developed a network in 25 counties at this point, and have been able to serve Medicaid and uninsured clients throughout this region. And so Healthy Alliance developed the IPA as an independent practice association of social care providers as a way to create sustainable funding after DISRIP. So what happened is that we wanted to contract with MCOs that would fund social care services through the network. And this would facilitate the clinic to community linkages. And we all, as I mentioned, when we applied for the funding, we were looking at this as a sustainability model. But part of what happened is that, and I'll talk a little bit more about this later, we've actually had to adapt some of our business model in the process. Yet we will describe, the IPA was really set up as a way for folks, no cost to join, providing the support for partner organizations. And in large part, a lot of the work we do was born out of this initiative. So as part of the work we do at Healthy Alliance, as I mentioned, it's not only the technology and the infrastructure, but we have referral navigators and a referral center that supports navigation for individuals in the community receiving services. We have a performance team that helps develop workflows for healthcare organizations and CBOs alike. We also provide data analysis, and in order to make this accessible to everyone, we have language line that we provide CBOs. This is something that healthcare practices frequently have and have to have, but we found that CBOs did not have access to a language line. We also have developed, an approach that helps practices and CBOs and other participants really with best practices for screening and, an approach that's trauma-informed. And for the small CBOs, which we think will reach more of our hard to reach community members, the most vulnerable, the IPA and the network has really helped level the playing field because the supports that we can provide make it accessible. People can get referrals and can get access to funding that they wouldn't otherwise from these organizations. So the way we work is we really believe that anyone should be able to get screened and get referral to services anywhere in the community. So we have relationships with churches and faith-based organizations, with schools, with public health departments, obviously the healthcare providers, MCOs and CBOs are foundational. And we work to get folks screened and simplify the referral process. Also between government programs, things like such as SNAP and benefits navigation and other services provided by the community. So I mentioned 25 county region, we manage the network. Unitas is in other counties in the state. So the lighter blue shows areas where we have partners and can have access to the network, though we manage the dark blue areas. And just so you can have an image of our network, now this is since inception, we have had quite a few community members connected to services through Unitas. That's 35,000. We find that there's community members that get connected to services outside of Unitas as well in our community. We get that information as well. And that's, you can see 275,000 individuals served by all our network partners. We have over 400 partner organizations. We have over 2,000 programs available. And you can see the details. We have had a lot of growth through the years. So as I mentioned, initially, we thought our sustainability would really come from the IPA. And as we found that MCOs were still risk averse to our model because, you know, the evidence is out there that it's like food reduces cost, hospitalizations, but it's like one single service. And our really holistic, it's how do we serve an individual with all their needs? Because we know, and the data shows that for every individual that has a need, it's most likely they have one too. So it's, you know, we provide employment assistance. We provide everything in the horizontal, everything you can imagine through different partnerships. And so our MCOs were willing to do one single service programs, but weren't quite ready yet because the data was not there. The studies weren't there yet with looking at our network as a whole. So that's part of the exciting part of partnering with Stanford. And also, as we've evolved, we had to develop like a blending and braiding solution, which is like the way to, that's everything being kind of proposed right now. And to do that, we developed multiple entities under Healthy Alliance that could facilitate contracting, again, with MCOs, with healthcare, grant funding, and other different sources of funding. So we have a nonprofit, we have an LLC, and we have an IPA. And I'm going to pass this on to Jonathan.
Thank you so much, Elena. So Dr. Rosenbaum's presented a compelling description of the social care network that Healthy Alliance developed. And this is a conceptual model that we've modified from Landers et al. To sort of ground our evaluation. So we at Stanford, our evaluation sciences team got connected actually with Healthy Alliance thanks to a colleague who I believe is in the audience, Julie Lawrence, who actually worked in both organizations in the past about 3 years ago. And so we really wanted to, as the academic evaluation partner, examine whether Healthy Alliance and its role as a trusted broker with healthcare, public health, and social services could have a true impact on solving the wrong pocket problem, with the goal being on the right, truly better health outcomes for individuals and communities. So next slide, please. So at a high level, our study aims were to really look at the original 6 counties where Healthy Alliance launched robustly and looking at the Medicaid populations that served there and comparing to those who didn't yet have access to Healthy Alliance's services, and examine the primary aim, whether there was an impact on cost of healthcare, but also then look at patterns of care and types of care, whether there were shifts in pattern, and particularly look at historically marginalized subgroups, examining who was accessing care and what sort of care, in both social services and healthcare, to see if this was starting to move the needle on health equity. So next slide, please. So diving a little deeper into those aims, you know, the total impact on healthcare costs was our aim 1. The second aim, looking at more granularly at ER visits, hospitalizations, and other patterns of care, and whether there was a shift over time when Healthy Alliance was present and connecting folks to social care. And then lastly, to dive into some of the racial and ethnic subgroups and see if there was who was actually accessing the social needs and whether this model was getting care where it was most needed. Next slide. So to do our methodologic approach is to use a difference in difference design, where we're looking at the members in the Healthy Alliance counties and specifically focused on Medicaid members and looking at their average cost per member per month prior to when Healthy Alliance launched in 2018, and then looking at their patterns after the launch to look at what the changes were, and then matching to controls in the adjacent New York counties where Healthy Alliance didn't yet have a presence, and looking at their average per member per month costs. Next slide. So to do this, we take advantage of linking 2 data sets. So New York has the advantage of an all-payer claims database, and that has both inpatient and outpatient cost and utilization data. And we're going to use about 5 years at minimum, including a couple years before and after Healthy Alliance launched in its core counties. And then we also have Healthy Alliance's robust data set. And so Healthy Alliance uses the Unitas platform as a tool. It uses the closed loop version. Some of you, I assume many in the audience are familiar with Unitas and other competing platforms that are social care technology, web-based platforms. And through that, they really have robust data on who they're interacting with. And because they have the closed loop data set and are supporting all their community-based organizations to use Unitas, they have all the social determinant of health screening from those clients, what the needs are, and what services they're being referred to and connected to. And so our analysis, by linking these data, we're able to see at an individual client level, people's social needs, their referrals to social services, and their healthcare utilization. But in the difference in difference analysis, we're really looking at per member per month at the county level. Next slide. So again, these are two data sets. It is probabilistic matching, with, as the last slide alluded to, in that what we've run into is that, in historical health services research, you often have a medical record number or a social security number. But in linking this data, the social service organizations aren't typically collecting that or using that. So we've had to come up with other techniques to link, using things like the first and last name, first few letters, and date of birth. But again, this really is key because it gives us such richer data that beyond what medical care claims data usually has around social needs and social service connection. Next slide. So just a little more detail on the cases. And the last bullet here gets at the probabilistic match that I just mentioned, which has been a lot of our focus in this year. But the cases we're focusing on are where Unitas first launched, and these are the 6 service counties listed up here. I won't read through them all, but they are quite diverse counties, more rural, upstate New York represented. Next slide. And so then the controls will be adjacent or similar counties that Unitas hadn't originally been there in those first few years. And by looking at those controls, we'll be able to do propensity score matching based on age, gender, as well as comorbidity risk scores to create a control cohort that's similar to those in the 6 counties that Healthy Alliances was first implemented in, but didn't have access to this robust social service network. And with that, I will pass it to my colleague, Dr. Todd Wagner, who will talk a little bit about what we're set up to detect and also early lessons we've learned in the process of this evaluation.
Yes, thank you, Jonathan. So as Jonathan alluded to, our primary aim, because of policymakers' interest in costs, is the total cost of care, or the per member per month, if you will. The Sparks data don't have payments. What they have is total charges. So our plan is to cost adjust the charges with the facility cost to charge ratio. For anybody who's worked in charge or cost adjusted charges or even cost data, you know that it's highly skewed and very variable. So one of the reasons for AIM-2 is to really delve into perhaps specific mechanisms that we would think about as being appropriate care versus inappropriate care. So the reason that ED visits is number one is we often think that we can avert inappropriate ED visits with appropriate preventive care or appropriate ambulatory care. And so we're starting to dig into some of these things, and then we'll look into some of the medications that people are taking through the Sparks data too. And then as Jonathan also noted, that our AIM-3 really, if you're familiar with the term heterogeneous treatment effects, what we're really interested in is perhaps we see something on the whole or we see nothing on the whole, but there could be very important differences depending on some subgroups. And so we'll really then delve into those subgroups to figure out, do they behave in very much the same way? Next slide. So in our proposal, one of our challenges is to know prior to running the study how big an effect we thought we could detect and measure. So what we ran is what's called a power analysis. And here is where we use data from VA, because VA is another safety net system, to try to estimate what we think we could see. So we took 5 random samples of veterans under age 65 who are more or less reliant on the VA for care, and we computed their monthly costs. And you get to see here, their monthly cost was $663. And what's really important here is the variance. So it's a very large variance. There are some people who are using a lot of care and some people are using a little care. And we computed what's, if you can see it on the right, is what we refer to as a power curve. and sort of gives us a sense on our sample size where we think we're going to detect. So we think we can see about a 9% change in cost. And if you put that in dollar terms, that's about a $60 per member per month. So we think we're doing okay, but there's always the chance that the true effect is smaller and we don't have the ability to see it. So that sort of plays out in the study. We'll see. Next slide. So early lessons from analyzing the data is the first is that the demographic data are necessary for health equity analysis, and that can be really challenging to collect. And I'll get into a little bit more detail on that. And then the other one that people keep alluding to is this cross-sector data linkages are new and really challenging how we think about the data, especially when we're trying to merge these two data sets that typically, especially in all the VA work that I do, you just have these identifiers because the healthcare system is so formalized and federated. But when you're working with social networks, you're not getting that level of detail. So it becomes very challenging to do this. Next slide. So the data linkage, like I said, so in many regards, if you have this master identifier like a social security number or a health ID, things can be really well linked across other data sets that have that identifier. But when you're linking across social care data, especially ones where the organizations don't collect that data, and there can be very good reasons why they don't collect that data, they don't need that data, or the people that they're serving are very distrustful of systems and may not want to provide that data. And so one of the challenges is how do you work with the data that they collect, which is typically things like name, sometimes date of birth, to try to link these things. And we often see things like location as being an important thing too. So what we've been really careful about is trying to find potential identifiers that will allow us to do what Jonathan referred to as this probabilistic match. So we're using name, we're using gender, or sex, I should refer to it as, and sort of location to think about a probabilistic match with the Sparks data. So that's still in process, and we're sort of working with Sparks through all the details on what that would look like. The other thing that you figure out is whether you're working with the Sparks data or the Healthy Alliance data is that you've got, whether it's discrepancies or just missingness. And so issues in capturing data, you think about the social community organizations not being accustomed to collecting these data beyond SSNs and so forth, but even questions about race, ethnicity, why would you want to collect that? I joke with my parents as they get older into their 80s, sometimes they misspecify their ages. It's clear when you have a 5-year-old, they'll even correct you and say they're 5.5, but when you get older, the age just becomes less of a number. And so, but when you're trying to use that age to merge, it becomes really hard and part of the probabilistic issues. And then we've really butted our heads against this cultural and systems to divide between what a organization like a healthcare organization expects in terms of data and PHI and sort of how they protect that, and then what grassroots organizations are often collecting and willing to share. And so my hope is that we'll have a broader discussion about that. Where we are right now in the project is trying to understand how to do this probabilistic match much better. Next slide. This client-patient issue of privacy really cuts both ways. I've sort of given you insights into how an organization thinks about it. But like I said, the clients, the people who are being served may have had different experiences with organizations and may be very reluctant to share. So in the VA work that I do, a lot of these folks have elected to participate in the military. And they see that as part of their duty, their sort of identity. And then if you ask them to participate in a study, and I've worked on clinical trials in the past, they see it as their duty to do that. And they're happy to sign consent forms. Sometimes they don't even think about it. We have to really be careful about the consent process in that case. Other populations see healthcare very differently than the VA. And so there's a lot of times hesitancy to share what we think of as these social needs information with their healthcare teams. And that can really affect what the data that we see and how we merge these. Next slide. So one of the things here is that we struggled on a lot, and these are data that we have, and you get to see race, ethnicity, and you'll see right off the top is that most people it's missing. And it's particularly missing for people who identify themselves as non-white. And so it gives you a lot of insights into maybe they don't want to share that. Maybe it's sort of personal information and sort of how you're getting that. And across the organizations in the graph on the right, you get to see missing race is just highly prevalent, but it also varies according to some systems. And that system could be just the organization seeking to collect it, or it could be the member willing to disclose it. So it happens in both ways. It's not always the member not wanting to disclose it. Sometimes the organization just doesn't see it as important. It doesn't need to collect it. So I think I'm going to pass the baton at this point, just to. But thank you.
Thank you, Jonathan. Thank you, Todd. That was, yeah, so I'll pick up right here on the data collection part, because what we did, the points that Todd just brought up are very relevant. We brought back this information that we saw that the Stanford team showed us, and we started thinking about, well, what's going on here? And we looked at the platform, right, because there's some systems level issues that could be going on. And it turned out that the Unitas platform is set up so that the default is to go to undisclosed. So that didn't give us information about whether there's no way to tell whether that's because someone declined to answer or because the staff member didn't even ask. So both are issues, as Todd mentioned. So we brought this information to our organizations, and Amanda will be talking about that from the organizational perspective. And it also brought up a lot of things, a lot of discussions that we got from community members, from CBOs, and then also we shared this information at a think tank where some of you might have been present also. We had a great discussion. And, there's the folks that are serving the most vulnerable may not be getting the demographic data. Are there instances? There are also instances where people are very grateful that they're getting asked these questions. So it goes both ways. Like on the one hand, there are considerations about, how comfortable people are answering the questions. And on the other hand, some people are, especially, folks that have been transgender. There was a case, cases in which, someone who's older, transgender, had never been asked their gender identity, and like all of a sudden they feel like heard and seen. So this is an important conversation. So I'm gonna talk about, just share, a couple things that we learned through the process. That definitely changes to, we've actually spoken to Unitas, and we're hoping that they'll adopt some changes on the referral platform that will make it so that everyone has to answer. Either we didn't ask the question, or the person didn't want to answer it, or there's an actual response to the question. No one has to answer the question if they don't want to, but just having a default makes real problems. The other issue is that we are getting many more answers through our rosters, through our EHR and case management roster. So we get information that's outside of Unitas, and that's more complete in terms of the demographic data. So I think what's happening is that these questions are getting asked a lot, and there's a lot of repetitive questions for the community member. And then there's also a lot of repetitive documentation for the staff member who's already put it into the org's case management tool. So maybe we'll get some insights from Amanda's perspective. But, I think some of the things we've been talking about and is, who should be asking the questions, what's the best training for individuals to ask the questions in a trauma-informed way, and what are the best practices, and do we need to ask these questions at every single organization, or is there like a balance between privacy of data sharing and because at the end of the day, we want the information so that we can do the analysis, but does it mean that everyone in the network has to ask it all the time, or can it be just asked once somewhere and then tied back to the rest of the data? So I'm going to pass this to Amanda.
Thank you. And definitely to echo what Dr. Rosenblum and Dr. Wagner said, there are a lot of challenges in collecting demographic data. So one of the biggest things that was definitely alluded to was client trust. So we have to recognize too that there's a pretty significant history between certain populations in the medical community too, where, there's been a lot of issues with trust, and rightfully so. So I think it's really important to consider those things and to also understand that, how people feel they can relate to you, potentially even by just looking on you, can really, impact whether or not you're able to gather that information. One of the things that we had struggled with in a couple different environments is really avoiding assumptions. So one instance I'll give you is we were at a vaccine clinic, and I was sitting down with somebody, and we were going over, he needed some assistance filling out the forms. And so I was going through all of the demographic questions, and he's giving me answers, I'm writing them down. And at the end, he looks over at me and he said, "I can't believe you really wrote that. Look at me." So we had to go back and explain that that's really not something that we can do, and that we really do rely on you to self-report. So it's, again, interesting to have some of those conversations. Another thing too, when we're going through demographic data, sometimes we get the question, you might go from race to ethnicity. People will say, "Well, I just told you I'm this race. You can't be this ethnicity. Like, you can't be both." So again, it's just interesting too, the way that people perceive those things, and how that they feel they should answer those questions based on their personal beliefs. So what it comes down to really is frontline support. The people that ask the questions really need to have a clear understanding of why it is they're asking those questions, and be able to communicate that clearly and simply to people as well. So, it doesn't necessarily feel great to people when you say, "Hey, like, I'm asking you these questions because we want the data," right? Or we want to collect this information. We have to be a little more clear of maybe potentially how it's going to be used, or, saying that this is something that we're collecting for XYZ reason. So I think that the kind of communication from the top down is extremely important to make the people that are asking the questions feel comfortable in asking those questions too, because again, what you said in terms of and the people that are asking the questions not always being comfortable even asking the questions sometimes, and maybe having things default to undisclosed. That's part of the issue as well too. So really, again, just kind of comprehensively supporting those people asking those questions, being careful not to make the assumptions, and then also just taking into account that there is some potential historical impact on your ability to build those relationships is really important.
Thank you, Amanda. And so, some of the early work we've done is really around understanding, again, everyone is asking about demographic data collection. And so we've put some energy into this understanding, and we've just heard a little bit about the different perspectives. Another portion of the work we've done early at the beginning of this funding and study is we were very proud. We published a study, or a paper solidifying the operational practices of Healthy Alliance as a social care network. And so, this is really describes the features of the Healthy Alliance model. And, we were very excited to have the support and able to get this out in the early stages of the work. So next, I wanted to talk a little bit about how things have shifted since we started our work at Healthy Alliance in 2018, and then with our study in the last couple of years. The environment for policy has changed dramatically. And this is a case in which policy is moving very quickly and is, kind of leading the way. There's lots of energy around health equity, and you'll see that the work we've been doing really aligns with CMS efforts on health equity. It's also, the White House has published the U.S. playbook to address SDOH. And ONC has taken on human service data. And that's really important because as we're looking at helping people holistically, we need to be able to see the data, not just from the community social care services, but also like everything that's happening in government. And so the whole government approach and the whole person approach needs to be advanced, again, breaking down those silos, not just at the community level, but also with government included. So, this grant and project have really positioned us well for the new environment. And Dr. Ford and the White House team, with a lot of input from others, have provided recommendations on how to address SDOH in their playbook. And the playbook really advances the work of backbone organizations and community care hubs, and also provides information on data gathering and sharing, and flexibility of funding for SDOH. So, as a community care hub, we're a community care hub with a social care network. We see our work very relevant here, and we're excited by the movement that has occurred in this space. So the other thing I wanted to mention, we wanted to mention, was that the Healthy Alliance model really aligns well with CMS efforts, to create clinic to community linkages. And, in order to advance health equity, you're going to have to operationalize social care delivery at a scale. And that's, to provide demographic data collection, screening, and referrals, and do this over scale is something that has not been done. And so CMS is now, you'll see with all their new programs, they all have these requirements. They also have health equity plans. And, and so we see that our model is really a way to operationalize all of this, and have been working with our healthcare partners in our regions and community-based organizations really to meet, we can meet these measures, essentially, looking at these social care network and community care hub models. The other mechanism that that's being looked at right now is the 115 waiver. And you'll see, there are 115 waivers that are used to pay for Medicaid, things that Medicaid doesn't usually pay for. And so a big proportion, you can see about you can see in dark blue as of end of January, the pending 115 waivers that are SDOH. There's 19 and 16 states that are looking at, I'm sorry, those are the approved, and 16 states that have pending SDOH waivers. We are located in New York State, and so we're very excited that in January, CMS approved a 115 waiver that funds social care networks across 9 regions, really creating the mechanism to integrate health, community, and social care and government services across the state, pretty much using, our model across the state. And we'll be funding, screening, navigation, and for high-risk individuals that fall into special populations, nutrition, transportation, housing. But there's going to be, navigation across all service needs that is covered. And that's what we've been working on here in the study too, looking at navigation. How do we coordinate service connections between all the different services? So not just looking at, while the waiver is going to fund nutrition, transportation, and housing, it's also going to fund broadly, connections to existing services in the community and government services and all the other HRSNs. So we're very excited. And right now there's like a big procurement process. So that's the current update of where the waiver is. So Amanda, I wanted to hear from your perspective, from the CBO perspective, what does this mean to you?
So from a CBO perspective, integrating medical care and social care is absolutely needed. It's really tough to address one thing without considering the other. So years ago, I worked in the ER on an asthma project, and we really were trying to engage people in this very successful program where we knew there were going to be good outcomes if people engaged. However, understanding the impact of social drivers of health, it was really important for us to provide kind of comprehensive support. So what they did was they paired a care manager and a community health worker in the ER in order to get people kind of have all those needs addressed, and then at that point begin to focus on some of the medical needs. So for example, we were working with one individual. She had just actually gotten out of treatment. She didn't have stable housing, and she actually had a cancer diagnosis that she hadn't been addressing for a number of years. And then here we are meeting her in the ER, trying to tell her, to get into this asthma program and to take her asthma medication. So it was really important for us to be able to kind of support those other things in order for us to see the kind of clinical outcomes that maybe we wanted to see in that area addressing asthma. it's really, really important to integrate, like I said, these two. One of the kind of successes we had was from my time at federally qualified health center, we actually had social health engagement specialists that we added to our team under a grant because of the absolute necessity, again, in addressing these social drivers of health. It was something that the FQHC had to apply for a grant to receive, but it was absolutely needed, and it was really supportive of us achieving any of those clinical outcomes. So again, it's really, really important for community organizations, social care networks, and social service providers to collaborate really well with those medical environments. At Healthy Capital District, currently, we are a community-based organization. We do a lot of insurance screenings and things like that, but we partner with Healthy Alliance. We do those screenings, and we work with medical providers to really gather the information, but also get people what they need to. We have anywhere between 11,000 to 15,000 people coming through our door every single year. So it's a lot of opportunity to connect, but we find people too are constantly coming in and visiting. And through those connections, we're able to maybe gather some information that we weren't able to gather before. But again, all of this just to say that it's really, really important that we work together, and we see the 1115 waiver as a huge opportunity for this to happen and to really start to strengthen those opportunities for sustainable funding for those social care aspects that are extremely important in any of the health outcomes we want to achieve.
Thank you, Amanda. So just we'll leave you with some few thoughts of the future. And, we're excited about forthcoming an economic and health analysis that Todd and Jonathan described. We think it's going to continue to help inform policies, and we really do think that the more we look at these models of community care hubs and social care networks and providing funding through healthcare funding through these entities is actually a pretty good way to help solve the wrong pocket problem, and without adding the operational cost of funneling all that money through healthcare. Because healthcare, above all, is also very heavily regulated, and so it's more efficient, to instead of running all food and housing and everything through healthcare organizations, to have non-healthcare entities manage those kind of services. So yet tightly connected between health and the social care services. So I want to invite the rest of the presenters to chime in, anything else they wanted to add. But thank you for joining. And go ahead.
Yeah, I'll pause here to see if anyone from the team wants to join in to add anything else before we jump into the Q&A section. Okay, I don't see anyone. Oh, well, Jonathan, do you have something to add?
I was just going to say there's some great questions coming in, so we can jump in there.
Perfect. Okay. I think the first question I'm going to ask is, I'm going to put Todd on the spot here because I see that you've responded to one of the questions that was asked. And so I thought it might be interesting to ask out loud and then have you answer so everyone else can see how you answered. But Alex Lavalley asked, what approaches will you implement to ensure you collect missing data that may impact the rest of your findings? What are the anticipated limitations?
Thanks, Karen. There's a similar question that asks a little bit about how are we going to get information for cases and controls in a systematic way? So if we use this difference in difference model, and we're using Sparks data as sort of our main analysis for aims 1 and 2, while we would like to know a little bit about the cases and controls, we can rely on the Sparks data for that information, and that gives us an overall estimate of the sort of the county level effect, if you will. Where we really fall down is really trying to understand whether specific groups are benefiting from the program or not benefiting from the program. And if you're an implementation scientist, you might be interested in that, be thinking about, are there things that we could tweak along the way that would really help one group or another group and help level the equity of these groups? And that's where you really need that information, because when I say the word group, we have the trade-off between what we think of as being a meaningfully sort of homogenous group or people who would self-identify in the same group and statistical power. And Amanda was talking a little bit about that. We've been doing some analyses on race, ethnicities groups, not in this study, but we see that it's not uncommon for people of Asian heritage to say, yes, they're also of Latino or Hispanic ethnicity. And we typically don't always sort of envision that in our groupings. And so we have to think about ways that get us big enough groups to analyze, but are also as best we can true to what the patient or the clients would think about them as being self-identified. And that's a real struggle that we all face, because if you really want to get into it, you end up much more qualitative than you end up in quantitative. And I don't know if any of my teammates want to say more about that struggle.
I mean, I'll just add it, acknowledging that race ethnicity is a social construct, and then there's all these other layers of complexity. There's other, groups that we are able to look at and we'll explore, including geographic and using zip code or location to social deprivation measures. So, and then all of this, the focus population is Medicaid. So there's some socioeconomic, there's heterogeneity there, but there, it is the population that tends to be lower income. So there's different ways to attack this, and we're going to be looking at all those different subgroups, but it's definitely imperfect and a challenge.
Thank you both. It sounds like you're thinking about this strategically, and maybe stay tuned to see what the team finds out on how they can address this. I'm going to ask, I'm jumping out of order here, but there's a question that came in from Kamal Henderson, and Todd, you just mentioned something about implementation and the importance of that in your project. So I'm going to ask this question, which is, I'm interested in understanding the implementation side of this initiative. Has there been a formal evaluation of implementation strategies to inform the field on how to effectively implement the process in other places?
So the team that's behind this, you see some of us here. There's also Steve Ash and some other folks who are very much implementation scientists on the team. I think I will defer the question to Elena to think about. I don't think we've examined any specific, what we would think of as formal implementation strategies and what's happening on the ground roots. There has been discussion about doing a qualitative study that would parallel this to understand exactly those details and more, but I'll turn that over to Elena.
Yes, thank you. So we do collect our own, just performance measures, but nothing in the context of a formal evaluation at the moment. We are looking at that qualitative study portion, as Todd just mentioned.
And I'll just add, I mean, that the Catalyst article that went in was our attempt. We joined as the evaluation team after they had already learned a lot of lessons, and that was our work with them to try and formalize a lot of the informal learnings that they had learned in implementing. So that article, I'd say, is an informal or semi-formal attempt to capture the implementation learnings. And we'd love to do some qualitative work. That's what we're exploring next. And I don't know if Elena wants to add some more, but really to get at, I think what's fascinating to me is they're working with very small grassroots community-based organizations, equally with enormous multi-county community-based organizations. Many of them, they've done a really good job, Healthy Alliance, to elevate local ownership, folks with lived experience relevant to the communities they're serving in their leadership and in input, and trying to figure out how important that is, especially as the goal is not just wellness, but health equity for historically left out populations. So Elena, that's something we've had a lot of discussion on. Like, you need to do qualitative to really get at those aspects and how important that is. And Elena, I'll pass it to you to see if you have anything to add on that.
Yeah, and I think a lot of the work has been done in terms of looking at, I think we really want to take a step back and look at what the impact is for the person who's receiving the services, and how that interaction with CBOs and how that interaction within our network supports them. And so I guess that's the work that we're hoping to do more and more of, because again, we can look at the economics and the numbers, but at the end of the day, we want to make sure that people are also feeling like it's a good, what are the best ways to optimize the network, and what are the things we can provide in terms of recommendations based on what we've learned. And a lot of that has to be informed by the actual person who receives the services and the CBOs who are participating in the network.
Great. Thank you all for your responses. And I know Jonathan mentioned the publication, which I did put in the chat earlier, but we'll also share that in our follow-up email along with the slides and recording. I see lots of questions coming in. If we don't have time to answer all of them, we'll make sure to give the team the rest of the questions, and we'll do our best to make sure that we touch base with you to answer those. So I guess that is my pitch here to say, if you do have a question, still put it into the Q&A and we'll make sure that it's answered, even if we don't get to it today. So the next question that we have is from Catherine McCann, and they say, Dr. Rosenbaum mentioned that MCOs are risk averse to the model. For MCOs that have come on board, what are some of the factors that helped them make this decision?
I would say that there's a lot about regulation and policy that was hard, things that we've had to work through. And we definitely have a lot of MCO partners that have been, we've worked with collaboratively for many years. And so right now we're seeing, I think as the state creates the mechanism for contracting, I think it's all gonna, it's gonna make the process much easier. There's a lot of hurdles. It's not just about the money. It's about, insurance, there's a lot of issues that you have to work with, just as like you're cross-matching the two data sets. It's like, how do you connect the different sectors, with like privacy, there's a lot of issues you have to work through. So right now we're going to see a time when it's going to become a lot easier as the state delineates the contracts, the privacy rules, all of that. It's going to become much easier.
Great, thank you. Anything else from the rest of the team, or do we feel like we can move to the next question? I see some nods. Okay, I'm going to move to the next question from Adam Davis. Can you provide additional detail about the target population and the service model? Are you enrolling clients in a personalized care service where Healthy Alliance is taking accountability for coordinating and delivery of care, or are you serving more of an added service layer to connect clients to social services?
So I think what you're at, yeah. So we're trying not to complicate that care coordination system. I think we're working with we're very cognizant of the fact that there's case managers and there's clinical care. There's like health home. There's like a lot of different layers of care in the community. So what we do is we work, for example, with a health system. I'll give you an example. We'll actually be an extension of their teams, so that the care managers and the teams might do the screening, and they, instead of making the referrals directly to other agencies, they might just send things to our referral center for our navigators to figure out which is the best organization. So we will call back the client. We'll also close the loop with the initial person that makes the referral. So we essentially function as an extension of teams, and we really tailor what we do to the organization we're working with. So how we function with, Amanda's organization, HCDI, might be very different than with another partner in our community based on what the needs are. But we have, the accountability piece, we do have network standards we require that all the organizations stick to in terms of looking at the referrals under a certain amount of time. We monitor that all the time. We make sure that the referrals are closed and that they're addressed. And if not, we try to look at those gaps.
Great, thank you, Elena. Next question from Samuel Bethel. In regard to who is asking demographic questions of enrollees and when and where these questions get asked, I'm curious to know how often professional social workers are being utilized as data collectors and stewards of data. We are generally trained in health, equity, trauma-informed care, and practice and program evaluation. Do we need to reinvent the wheel for health and social care integration?
Yeah, no, thank you. And I appreciate that. We actually have, I think the issue is this is happening. Not every agency has, not every organization has someone who's trained in doing this work. And so what we're trying to do is get those best practices that exist and disseminate. We've been, creating training to disseminate on a lot of it. Again, we're working with social workers as primary folks to share with us their best practices, because we don't need to reinvent it. We're also working with experts on LGBTQ care and on how to ask those questions Because again, it's also we're looking at healthcare systems that don't have the training. We're looking at CBOs that are serving special populations, but we're also looking at CBOs like food pantries. And so it's like, I think we're drawing from that expertise, but we can't provide a social worker in every location, if that makes sense.
Thank you. Moving on to the next question from David. Trying to measure impact on health costs in the near term misses the large payoffs that develop over time. Are you looking for metrics that point towards savings in the future? And are you looking at benefits outside of CMS and outside of health?
This is probably more directed to me, but others can chime in here as well. I think in all of our studies, we would love to be able to collect long-term outcomes, whether it is a clinical trial that I work on or another study. A lot of it just comes down to, some cases, the funder not being willing to fund it, or it's just hard to do. And sometimes when you get farther away from the intervention that happened, you get more, sort of confounders that could happen. The people move away. They could leave New York. And so it becomes harder and harder to get the sort of true causal link between that. So the hope is that we see a difference here in the near term. We could then apply for funding to continue looking for that. And then Carrington, I'm going to pause there. There's a second part of that question that the person asked, and I just lost thread of it.
Let me ask it again. The second part is, are you looking at benefits outside of CMS and outside of health? Is that the part that you were looking for?
That is, yeah. So we've done some of these analyses in wrong pocket syndromes from sort of the converse, what happens when the healthcare system stops doing it. And so we're trying to sort of look at this from different perspectives on trying to get a better handle on how do we build the connections between healthcare systems and community organizations. There's another person who asked just a great question, which is, hospitals don't want these bridges or don't want to necessarily navigate these bridges all the time because it's very tedious for them to build a bridge with a very small community organization. I think that's the beauty of what Elena is trying to do with the IPA, is make it easier for them to work with buses or transportation. But that's really right. And we also don't want to fold it under a healthcare organization that's very expensive labor, that's highly regulated. And so we have to figure out ways to build sort of successful bridges that allow both to thrive. Elena, did you want to add anything to that?
No, I think you thank you.
Thanks, Todd. I think, so we have 2 more minutes left. I think we can answer maybe one more question. I'm going to put Jonathan here on the spot. I see that you've answered a question that somebody asked, and I think it's maybe a short one that we have time for. So Liz Nelson asked, do you see being able to use this model to collect data to inform policy and system changes to equitably advocate for policy and system improvements to address these issues upstream?
I mean, I would argue that Healthy Alliance already has. I think they were very much a presence as the New York waiver was considered. But I think one of the important things that looking at the social determinants of health screening that Healthy Alliance is collecting, I mean, they're getting dozens of different domains. It's not just, housing, food, and transportation, but many other domains. And so I think policies like the waiver may initially only be directing money specifically for a narrow set. And so this analysis and the data from Healthy Alliance can tell us, okay, which of these are the most prevalent needs, or which are maybe correlated most with addressing them is most correlated with improved outcomes. So I think that level of granularity and the learnings from Healthy Alliance are likely to continue to influence policy, and hopefully we have the economic analysis to motivate the payers to jump in and do more.
Great, thank you. So we have 1 minute left. I want to take some time to thank the research team for putting together this presentation and for providing some really great updates and all the work that they've been doing. I really appreciate the time that you took today to come and present all of this work. And this is an ongoing research and progress webinar series. We will be back in 2 weeks with another Systems for Action research project who will be presenting on their work. And then if you join the Systems for Action newsletter, you'll get all updates on publications and products and findings that are coming out from this team. And we'll also send everyone who registered today an email asking you to register for their next webinar, which will be probably in about a year when they'll have some final results, I'm thinking. Thank you again for joining today. I think that's all we have, and I hope everyone has a wonderful rest of their day.
Thanks, Carrington. Thank you, everybody.